So, good morning, and this is indeed an honor and a privilege to be invited on an International Snakebite Awareness Day. And I consider both as an honor as well as a privilege because snakebite is a topic which is dear to both CMC-Vellore as well as MGIMS Sevagram. And on the occasion of this 4th International Snakebite Awareness Day, I think it's very prudent that both CMC-Vellore and MGIMS Sevagram break the silos, join hands, work together, and ensure that the huge morbidity and mortality that India is witnessing because of a neglected disease called snakebite, it is reduced as much as we can. I would like to thank the organizers, in particular Anand and Dr. Ravi Karral, for asking me to speak on this occasion. And I'm also indebted to all office bearers and organizers of this meet for thinking me worthy of speaking on this occasion. So this is a quote that I have picked up from a very recent publication, 2021 publication, which says that every year people lose their livelihoods, limbs and lives to a disease that is as neglected as it is ancient. And the disease is none than snakebite envenom. In fact, in this recent article, which goes on to describe the impact and influence of snakebite envenom in resource limited setting, the authors very rightly pointed out that snakebite envenom is an orphan disease which is sadly neglected, barely looked after, and is waiting to be adopted. So the objectives of my talk briefly are that I'll be speaking on the burden of snake bites, drawing your attention to the estimates of snake bite all over the world, Asia and India in particular. Then I would deal with current diagnosis and monitoring of envenoming. Then I would deal with challenges and limitations of existing antivenom therapy. Next, I would draw your attention to the strategies to prevent, reduce, and control morbidity and mortality because of snake bite. And finally, I would tell you that what exciting things are involved both in diagnostics as well as therapeutics so far as snake bite is concerned. So the very important thing is that when we deal with any disease, it is extremely important for us to know that, okay, what is the burden of the disease? What's the prevalence of the disease? What is the incidence of the disease? How many people get the disease? How many get morbid? How many leave the hospital? How many survive? How many get disabled? And how many die? So two very important papers have appeared in the last decade so far as estimates of snakebite morbidity as well as mortality are concerned. And the first paper was published way back in 2011. And this is a paper which is very often quoted when people talk about epidemiology of snakebite. And the paper has attracted the attention of almost all stakeholders so far as the snakebite morbidity and mortality is concerned. This is so because till this paper was published, both morbidity and mortality of snakebite was very grossly underestimated. In fact, if you go by the previous statistics and the recent statistics from the Ministry of Health and Family Welfare, Government of India, as recently as in 2016, the government said that there are just 1,300 deaths of snakebite all over the country. Now, these were official estimates of snakebite mortality. And this paper, based on a nationally representative mortality survey, very clearly showed that in randomly 6,500 randomly selected areas between 2001 and 2003, this survey estimated that at least 46,000 men and women in India are dying every year. That most of these people are coming from rural areas. Most of them are men. They are the principal breadwinners of their family. And for every patient of snakebite who dies, there are at least 4 who get a permanent disability or face the specter of having their leg amputated or are made to walk either on crutches or need to take the help of wheelchair. This paper also very clearly said that for every 2 HIV deaths in India, there is 1 snakebite death. Considering the huge importance that we very justifiably and very rightly give to the HIV, it is also important that we do not neglect snakebite and make sure that snakebite is accorded the right importance that it richly deserves. The second paper came very recently. It came in eLife. Again, some of the researchers from the original 2011 studies joined hands and then they looked at trends in snakebite mortality in India the last 20 years. Again, just as the first paper possesses the punch of being an eye-opener, this eLife paper also added to that punch. And it kept on saying that a decade has gone by and yet the government seems to be in a denial mode. We probably are not collecting data properly. We are not able to interpret those numbers properly. And we continue to underestimate both morbidity as well as mortality from snakebite. And this was occurring because only 20% of the people of snakebite would have access to the hospital or would die in a hospital. A large proportion of people would die either in their homes or in the primary health centers or some obscure rural remote corners of the country, and they would die almost unrecorded, unwept, and unsung. So this study, which was again based on the nationally representative mortality study, brought about 4 very important points, and they were that when we talk of snake bites in India, over the last 2 decades, at least 1.2 million people died of snake bite. Now, this is a huge number, 1.2 million people dying of snake bite, and nobody is talking about them. The government has studied silence over them. The media fails to take their notice. They are not published in newspapers, and there are very few research papers published from India which bring about this very disturbing fact of about 1.2 million snakebite deaths occurring in India every year. Next problem is that this study also showed that at least 58,000 Indians are dying every year. It's quite possible that even this 58,000 is a gross underestimate, and the number could be as high as about 100,000 Indians dying every year if every snakebite death is recorded and snakebite indeed becomes a notifiable disease. The study also explained that if an average Indian survives an age of 70, then there is a 1 of 250 chance of this Indian dying of a snake bite. Now, this is a huge number. We talk about heart attacks, strokes, COPDs, kidney diseases, cancers, and accidents. But nobody talks about a mortality from snake bite simply because it is occurring in rural and remote area. But 1 of 250 risk of dying before one attains the age of 70 is indeed a very big number. And lastly, that there's a 1 in 4 chance that a victim dying of snake bite either is a small child or an adolescent. Now, if small children, adolescents, main principal breadwinners in the family, people living in the rural areas, people with poor access to healthcare are getting bitten by venomous snakes, are not getting a hospital access. And even if they happen to get into the hospital ICU, they are dying because of a lack of proper resources or lack of science into the medical care. But this is indeed a huge, huge problem which we are not ever taken care of. In fact, let me explain to this man another figure, isn't it? Instead of talking in terms of decades and years and months and days and hours, let me talk in terms of minutes. So every 5 minutes, there are at least 50 people in India who are bitten by snake. And out of these 50 people, only half of them are lucky to receive an antivenom. The 4 would get permanently disabled, would be made to nurse their chronic injuries or non-healing ulcers or large necrotic areas, or might have an unfortunate specter of getting an amputation, and at least 1 will die. Now, if every 5 minutes 1 Indian is dying of a snake bite, this itself indicates the magnitude and severity of the problem. So having these numbers and having noted that right now we are grossly underestimating both morbidity as well as mortality because of snake inhalation, let us see as to how the patients of snake bite are being currently diagnosed and treated. So how do we diagnose? How do we identify the snake? And how do we assess the severity of envenomation? Characteristically, one of these patients are admitted to a primary health center or a district hospital or a medical college. Well, we often ask them that, well, have you brought the snake? Have you killed the snake? Or have you taken a photograph from your mobile cameras? And then we try to make some intelligent assessment, a guesstimate about who that snake could be. Or we ask about the circumstances of bite, when were you bitten, what were you doing, were you sleeping on the floor, were you working in the field, where did the snake bite, on the hand or leg? And then again, we try to make some intelligent estimates based on the circumstances of the snake bite. We also rely a heavy deal on patient's description that the snake was small, the snake was long, it was black or yellow or striped, or it looked very aggressive, or it really looked venomous. And people have got their own versions and own ways of articulating the stories about snake bites. And finally, thanks to a 2009 Sri Lankan study, we also make a diagnosis based on characteristic clinical syndromes, trying to distinguish a cobra bite from a great bite, a great from a Russell viper, and a Russell viper from a Saskate viper. But put together, whether there are photographs or patient circumstances or histories or the characteristic clinical syndromes, A, there is a big deal of an overlap between the snake envenenations. B, often the overall diagnosis is neither accurate and or reliable, and more often than not, we are made to inject an anti-snake venom in the patient's veins, relying on data which is not very accurate, numbers which are not very reliable or trustworthy. So ever since Professor David Worrell brought this test at the patient's bedside, 20 WBCT, it has been used almost all over the world as a bedside cheap effective test to pick up snake envenomation. So while the beauty of this test lies in the fact that it is low technology, in fact, it's priceless. It's a test which, in fact, it requires no money. It can be done by an intern or a nurse or a paramedic at the patient's bedside. And for the 50 years, it has been used extensively all over the world. But then it is important that although the test has several virtues, that it is simple, that it is point of care, it costs no money, it is a low technology, and can be easily done even in the rural and remote areas of the world. It is very important for the scientists to understand, well, what this test is really all about, what are the estimates of sensitivity, specificity, and predictive values of this test, and how much this test really help us in ruling in or ruling out a snake bite. So very recently, in fact, last month on 10th August, Anand Zakaria and his colleagues published a fantastic systematic review at the and a meta-analysis of the diagnostic test accuracy, where they looked at 20-minute WBCT as an index test and used either an PT-INR or a fibrinogen levels as the reference standards, and tried to figure out, based on a published research on diagnosis of snakebite by 20 WBCT, how good or how bad this test is. And here are those numbers. 6 countries, 12 studies, there are about 2,270 participants in which this test was used. This is a published research. The test has already been used on thousands, if not lakhs of patients all over the world. And they found that in detecting an INR greater than 1.4, the test had a sensitivity, the estimate was 0.84 and the specificity was 0.91. And as for detecting fibrinogen level for less than 100 milligram per deciliter, in fact, Dr. David Worrell calls it as a poor man's fibrinogen assay, its sensitivity was 0.72 and specificity was 0.94. But look at the second row and sensitivity column. The estimate is 0.72. The lower limit of confidence interval is 0.58. And if we look at closely at the lower limit of 95% confidence interval of 0.58, we mean that in as many as 42% of patients whose fibrinogen levels are less than 100 milligrams, the test is not picking up coagulopathy. Now, this is a serious false negative rate, that if 4 out of 10 people with proven coagulopathy are not picked up by 20-minute WBCT, and there could be a variety of reasons that that test is not reproducible. The people do not often stick to how to do this test. They would often not get a new, clean, dry test tube. They would not stick to the 20-minute rule and so on. But this lower estimate of 0.58, so far as the sensitivity is concerned, it really worries me. The specificities are good, 0.91 and 0.94, which means that if the blood is not clotting, well, this is indeed probably a viper bite, or this is indeed a hemotoxicity. But its sensitivity leaves me slightly surprised. And so now let me talk about the snake venom, isn't it? And this is one of the most revered herpetologists, Ron, who has been working in India for the last 50 years, and single-handedly he has contributed so much to the epidemiology of snake bite, to the understanding of snake, how their venoms come from, where do those venoms come, and so on. And so on. So Ron is surrounded by the snake catchers who belong to the Irula Snake Catchers Industrial Cooperation Society in Chennai. And this is a society which is a major supplier of venom for the whole country, both for research purposes and as well as for inoculation into equines for raising antibodies. The Irulas catch the 4 big species from the wild. They would pick up those snakes, they would milk them at weekly intervals. They will make sure that after a month of a milking, these snakes are again sent back to the wildlife from the very areas that they were picked off, and they do it after tagging the snakes. And then the venom that's obtained is then ideally lyophilized, it is freeze-dried, and then it is stocked, procured, and sold as per the government guidelines. The Irulas have a permit to milk up to about 8,000 snakes a year from the 4 big species. And if there is one community and if there is one area which has made huge impact so far as procurement of snake venom is concerned, well, the credit completely goes to this gentleman and the Irula community with which he is working for the last 5 decades. Again, a photograph of an Irula now milking a snake and capturing the snake venom, something which they do almost 8 months a year. But the irony is that wonderful as the work of the Irula community is, and the tremendous efforts that they are investing into getting these snake venoms and making sure that these snake venoms are converted into snake antivenoms, and the antivenoms are distributed all over the country. The problem is that over the last 100 years, the way we are preparing anti-snake venom hasn't changed much. In fact, history tells us that way back in 1892, Dr. Kalantri, who is also well known for his research on a BCG vaccine, introduced anti-snake venom for the first time in the management of snake poison. And he wrote, and I quote, that 12 days ago, I happened to see a very interesting experimental research on the venom of the famous snakes called najas that every year kill in India alone about 21,000 people. So in 1891, this French physician, French microbiologist, Calmet, published his first paper on using anti-snake venom in the victims of cobra bite, and published some fantastic results by the anti-snake venom that he had designed. The trouble is that even today, 100 years later, we continue to make, continue to prepare, and continue to treat the patient of anti-snake venom in much the same way as Albert Calmet had done in 1892. So although the science has advanced, although the technology has crept into the patient's bedside, huge progress has been made in pharmacology. Well, the current method has changed little since the 19th century, which is indeed a cause of worry for the people who treat snake bites. The WHO in 2017 made it mandatory to follow the prescribed good manufacturing practices called GMP guidelines for both the manufacturing of ASV and procuring this ASV. So WHO has very clearly spelled out that who these animals should be. So this could be donkeys, mules, horses, and more recently camels. And the WHO in its 2017 document very clearly spells out that these animals must be at least 5-year-old, that they could be bled for 9 months a year, but they should have a compulsory vacation for about 3 months where they are rested, that the ponies could be bled till the age of 14, horses 22, and mules till they reach 25 years of age, that the animals must have a compulsory vaccination for certain diseases. They must be screened before they are bled, and not more than 10% of the equine plasma should be obtained at a given time for preparation of anti-snake venom. And more importantly, to make sure that we do not inflict cruelty on these animals, the horses must be kept in their facility after they are no longer used for antibody production. It is extremely important to make sure that these recommendations from World Health Organizations are properly adhered to, because if you do not adhere to these good manufacturing practices, the quality of venom that we are using to prepare anti-snake venom could go considerably down. So what are the problems in venom? First, that snakes are a protected species as per the Schedule 11 of the Wildlife Act 1972. I mean, you cannot capture a snake, you cannot kill a snake or milk a venomous snake without an official permission. Now, this act was passed in 1972, and this act was necessary in 1972 because there was a very thriving snake skin industry which was going on till 1972. And this industry, because of its commercial reasons, was responsible for killing of hundreds of thousands of snakes annually. In 1972, this practice was stopped. But the flip side is that now the venom that we are getting is in extremely scarce supply, because very few institutions are permitted to milk venom commercially. And similarly, it is not very easy to get common crate or scaled viper venom, and therefore the industry is finding it rather difficult to make a polyvalent venom because of a shortage of common crate and scaled viper venom. And lastly is the cost. Well, today the treatment of a snake bite is more expensive. This is something that we realized in our hospital, which is a not-for-profit public hospital, that the treatment of snake bite is more expensive than a treatment of a heart attack or a pneumonia or a stroke. Another problem is that till now the India is not following the captive breeding of snakes for the venom collection. The snakes are procured from the wildlife, from the forest. They are picked up, they are milked, and then they are sent back to their home. But this leads to two problems. And if India starts following the captive breeding of snakes for venom collection, then we might reduce the number of snakes which are handled and relocated. And also we could get healthier snakes than those which are available in the wild. And this will dramatically improve the quality of the venom there. So having looked at venom, now let's see about the antivenom scene, anti-snake venom scene in India. So the existing Indian antivenoms are produced exclusively against the big four Indian snakes, the cobras, the kraits, and the two vipers. And antivenom is expensive. I looked at our hospital data last year, where I found that in 2020, our hospital procured some 2,100 vials of anti-snake venom, and we paid $357 for each vial. The irony is that the pharma industry is making tons and tons of profit even on a life-saving medicine, which is likely to save lives of rural, marginalized and deprived population. And look at the MRP. The MRP is 625. What we get is 357. What the MRP is 625. So this is a huge profit which the pharma industry or the middlemen are making when the anti-snake venom is made available to the hospitals. The irony is that today, if you talk in terms of a cardiac drugs, for example, atorvastatin, there are at least 300 or 400 brands which are floating around the market. Almost everybody is making atorvastatin. Everybody is making oral anti-diabetic and oral hypoglycemic and antihypertensive drugs. But when it comes to anti-snake venom, there are just 6 companies right now which I have listed here, which are manufacturing anti-snake venom. And even these companies are facing problems. The government is facing problems. The hospital is facing problems. The doctors are facing problems. First, the anti-snake venom, if it is made available in liquid form, it is unstable. It requires to be refrigerated between 2 and 8 degrees centigrade. Many times you find that there is a poor effectivity of anti-snake venom, and I shall soon be dealing in my subsequent slide as to how best can we explain this poor effectivity. It is relatively not effective against presynaptic neurotoxin. I mean, all the country, I find that patients of great bite, when they come to the hospital with ptosis or not being able to swallow or a breathing difficulty or requiring intubation or a mechanical ventilation, are given anti-snake venom, 10 vials, 20 vials, and 30 vials. Little do we realize that by the time the patient has developed presynaptic neurotoxicity of a great bite, the anti-snake venom has lost that window and it's no longer effective. Similarly, all over the country, we find people with just swollen limb or local envenomation being given anti-snake venom, and anti-snake venom has no efficacy for preventing necrosis or dealing with local swellings. So if we teach the medical students, interns, residents, practitioners, PhD doctors all over the world that they are the 2 areas where the antivenom might not work and we should not be using antivenom right, left and center, then probably we could be using antivenom with a much more scientific evidence and we would be able to preserve the anti-snake venom which is already in scarce supply. The adverse reactions are pretty common. There is a 1 in 4 chance that a patient who is injected an antivenom might get an adverse reaction. And then because of the reasons that I have already spelled out, it is challenging to produce. It is challenging to even distribute anti-snake venoms. With the result that almost all primary health centers in my area, there are 27 primary health centers in Varda district. And I asked many medical officers how much you get. And they all said that we will get about 10 or 20 vials every year. And the government would ask to manage, quote unquote, manage with this 10 or 20 vials of anti-snake venom. And this breeds another problem, which I shall be dealing in my subsequent slides. Another thing that we must understand that there's a difference between efficacy and effectivity, that what works in a lab or what works in animals might not work in human beings. So anti-snake venom might completely neutralize snake venom when it is injected in a mice. But what works in a mice might not work in a human being, something which we, the clinicians, must take note of. And why ISBAD doesn't work? Because the quality of antivenom depends on 2 factors. What is the quality of venom that you are using? And if you are not using the WHO GMP 2017 guidelines, the quality of anti-snake venom would leave much to be desired. It also depends upon the quality of antibodies which are raised in horses. And we know that there are a number of factors involved right from the snake and the horse to a human being, which can destroy the quality of anti-snake venom. So as I said, and there are several very interesting papers which have been published in 2020 and 21, which clearly show that an ASV which is prepared against a venom sample from Chennai might not work in Chandigarh. An ASV prepared from, say, Coimbatore might not work in Kolkata. So there are the huge geographical differences. There are interspecies and interspecies differences so far as the snakes are concerned. And an anti-snake venom which is prepared from local snakes in Tamil Nadu might not work in Tripura there. So the anti-snake venoms that are prepared all over the country against 4 big ones might not be effective against regionally specific snakes. with the result that often, say, a person in Punjab gets an anti-snake venom. It's bitten by a viper and gets an anti-snake venom, which comes from a Tamil Nadu, isn't it? The WBC-TC keeps on deteriorating. The patient keeps on getting larger and larger doses of anti-snake venom, but the blood refuses to clot, and often the patients die. Now they die, or the blood doesn't refuse to clot, not because their treatment is scientific, but simply because the anti-snake venom which is being used and which is being infused in their veins is coming about 1,000 miles away, and those snakes are different. The Punjab snakes are different, and what holds true in, say, Chennai might not hold true in Chandigarh. So the irony is that till recently there were only 2 districts from Tamil Nadu which was producing snake venom, anti-venom, for 718 districts of the country. And if we see these 2 very important papers from Toxicon 1988 and Toxicology 2014, they again help us understand why the anti-snake venom doesn't work in different areas of the country. But very exciting, isn't it? And I'm very grateful to Professor Karthik Sunagar, who shared with me his 3 very important papers on Twitter barely 3 days back. The papers I was not aware of, where Karthik Sunagar and his team, who are working in the Evolutionary Economics Lab in the Center of Ecological Sciences, Indian Institute of Science, Bangalore, showed by meticulous research that, well, the snakes are different. There are differences in the intra-population and interpopulation. There are large variations across the country. And very surprisingly, now his colleagues and his scientists have found out that in a geographical area as wide as only 50 kilometers, the snakes differ. Now, this is an extremely surprising and rather worrying feature that an anti-snake venom prepared in a certain state might not work in another state, and this is happening for, as the research shows, for cobras. They also found that the anti-snake venom procured from Chennai didn't work in this monocellate cobra in Kolkata and certain districts of West Bengal. And they also found that when it comes to Russell viper and even great bites, well, anti-snake venoms are not working as beautifully as they are working so far as the local populations are concerned. So this is something which the clinicians, epidemiologists, and policymakers and the governments must keep in mind, that the snakes are continuously evolving. The snake venom produced in a particular geographical area might not work in another area, and we must very clearly understand why the anti-snake venoms are losing their efficacy in different quarters of the country. And I picked up these excerpts from 3 very leading snakebite experts from the country, and Jadi Menon, who is a cardiologist but hugely interested in the management of snake bites, recently wrote that the ASVs made from venom extracted from snakes in Chennai will only be potent in the southern region. Its potency drops dramatically as you move further. And Nishiganda Naik, who works at the Hafkin Institute, wrote that the venom for the ASV should also be extracted from the same region as where it is going to be stocked and to be used for treatment. Venoms are not only different geographically, but they also keep on evolving all the time. And Priyanka Kadar and his team, who has done a phenomenal work so far as primary prevention of snakebite, engaging local communities, teaching communities about the primary prevention of snakebites, do's and don'ts about snakebite, also says that each PSC should be given enough anti-snake venom according to the population that they serve. So the bottom line is clear. You must get anti-snake venoms based on snakes which are locally prevalent, isn't it? One-size-fits-all approach for the entire country might not work. Anti-snake venoms only for big fours might not work in several sections of the country. So having looked at numbers, having looked at venom and antivenom, now it makes great sense to draw your attention to this fantastic paper published in 2019 which tells us about the strategy for a globally coordinated response to a priority neglected tropical disease called snakebite envenoming. And till recently, snakebite could get in and would get out from the list of neglected tropical diseases in the country. But this table very clearly shows that if you look at some of the competing diseases which found their way into the WHO's neglected tropical disease. For example, cholera, isn't it? Every year about 68,000 Indians are dying of cholera. Leishmaniasis, the number is 24,000. The ascariasis, the number is still small. Very few are noticed directly from hookworm or filariasis. But all these diseases could get into that list of neglected tropical disease. And look at snake bites, about 100,000 deaths, at least 100,000 deaths from India every year. The global prevalence is this. The population at risk is 6 to 7 billion. And yet, it took a lot of efforts from almost all stakeholders to persuade WHO to enroll snake bite in the list of neglected tropical diseases. So, in 2013, the snakebite was removed as a neglected tropical disease. And the WHO argued that we were forced to remove snakebite as a neglected tropical disease simply because there were no numbers, there was no data from India, and the numbers told us that only about 1,000 or 1,500 Indians are dying of snake numbers too small for a disease to be awarded entry into the tropical neglected tropical disease. So in 2017, thanks to a large number of stakeholders who worked relentlessly and were able to persuade WHO, snakebite could get entry into the WHO NTD portfolio. And now the WHO has a very ambitious plan. And it says that we should aim, and our goal should be that by 2030, the next 9 years, we should be able to reduce the mortality and morbidity of snakebite by 50%. So how do we do that? And the World Health Organization and Dr. Williams has very clearly told us that there are 4 important strategies to achieve this aim. The first is that we must empower and engage communities. First, we should focus our attention outside the hospital and target at the very site of action where the snakes are found and where the people are being beaten by snakes. Then we should have a very strong health systems. 3, we should aim at an antivenom which is potent, which is effective, which is efficacious, which is devoid of side effect, and an antivenom which indeed works against a variety of snakes present in a local geographical area. And it is time that the regions, the states, the nation, and the entire world for that matter must break their intellectual silos, join hands together, and design strategies which are ultimately all aimed at achieving this goal of reducing mortality and morbidity by 50% over the next 9 years. I happened to read 2 extremely important papers, and I believe that they are the 2 papers which must be read, reread, and digested and assimilated by every person who is interested in snakebite. The first comes from CMC Vellore, where Dr. Ravikar Ralph and colleagues very eloquently argued about what snake bites are all about, what do they mean, what are the problems, and also what are the solutions, and what research areas we need to focus on if you want to reduce the snake bite deaths in South Asia in general and India in particular. Another paper was written just a couple of months back by Dr. Joy Kumar and Jadid Menon and R.S. Dhaniwal. Is called a white paper on venomous snake bite in India, and this paper now adds to the information which is already available from a paper by CMC Vellore researchers. So, what do we need? What do the victims of snakebite urgently need, and what should India do to reduce the mortality and morbidity from snakebite? The first is primary prevention. The second is that we must strengthen our rural health services, something that we have learned during the COVID-19 pandemic, that how poor, how marginalized, and how neglected and how inefficient our primary healthcare is. That we must educate or people to ensure that they have rapid access to the hospital. Fourth, we must ensure that we have rapid and accurate point of care tests. The WBCT is almost 50 years old. It's time that now we replace 20-minute WBCT with something more accurate, more rapid, more reproducible, and more trustworthy tests there. It's important that we must have safe and effective antivenoms, that the hospitals are well equipped in terms of good ICUs, dialysis machines, ventilators, and we also ensure that our medical students, our interns, residents, practitioners, medical officers at the primary health centers, our ANMs, ASHA workers, everybody learn, our school children, teachers, everybody knows about snakebite, and we keep on teaching them science. We keep on training them on do's and don'ts, and we help them how to treat snake bites in a more appropriate and more rational manner. And finally, we need a substantial research because this research is a very painful area so far as the entire spectrum of snakebite is concerned. So how should we manage snakebite in the pre-hospital setting, and what are the problems? At MGIMS, when we talk to the communities, isn't it, and kept on wondering as to why the people are coming to the hospital, why their access to the hospital is delayed, and why they are getting irrational therapies near their home, we found several hurdles. So once a victim is being beaten by a snake, the home itself is a pain area there. And then most victims of snake bite, even in our area, where the medical college is quite nearby, would often put their trust in snake healers. The snake healers are locally called in different areas of the world as Kaviraj, Mantrik, Babas, Sadhus, Chikitsaks, and so on. And they use their own indigenous ways and methods to treat people with snake bite. And people do trust them. In fact, I found that people have a much more, people trust them more compared to they trust the modern hospitals and modern doctors and modern ICUs. Primary health center, I will soon be talking about. Then the patients are referred to the district hospital, and finally they come to our hospital. So often the people would travel hopefully from their home, bypass a faith healer, go to a primary health center, reach a district hospital, and finally arrive in our ICU. And they keep on traveling hopefully, but often they do not arrive at the hospital. Many of them drop dead as they go through this Odyssean journey from home to the hospital. So to make sure that every victim of snakebite is offered appropriate, rational, and evidence-based care, it is important that we must increase the awareness of preventive measures. And what some of those preventive measures could be? They're very simple. We must have a rich data on epidemiology and estimates of burden. We must know where are the cases of snake bite occurring, what are those hotspots where the snakes are biting people, what are the activities that they are indulging in, and why the people are being beaten by snake bite. I mean, are they being beaten because their homes and their surroundings are cluttered? There is a lot of firewood around the home. Are they being beaten because, well, people don't have shoes, people do not sleep safely, or patients do not walk safely, carrying a torch with them? Or is it that, well, the people have put all their hope and all their trust and all their money on faith healers, and why we are not able to attract their attention? At MGIMS, our local artist, Mr. Dinesh Gudade, he's a great artist who keeps on making wonderful health education materials for the communities. And we asked him to prepare material for our local communities in and around Sevagram, trying to educate the people. And there are the couple of do's that as we will tell them that as you are being beaten, well, make sure that you reach the hospital. This could be a primary health care, a district hospital, or a tertiary hospital, or a medical college. But get into the hospital as fast as you can. And do that, call 108, which is a local number for an ambulance. Or we picked up this thing from Professor Sharma's study from Nepal, where the patients of snake bite are transported to the hospital with someone riding a motorbike. Obviously, this is illegal, but then when it comes to saving the life of a snake bite, then often we need to turn a blind eye to the rules sometimes. And the other don'ts that, well, we educate our local communities, but that don't panic, isn't it? The chances are quite high that you might be bitten by a non-venomous snake. And even if you have been beaten by a snake, then there are hospitals around which could probably minimize your misery and save your life. Make sure that you do not use any of these things. 2 and 3 very important don'ts are this, that, well, don't use a tourniquet. Don't incise the wound by a blade or a sickle, and make sure that you don't put all your money on these faith healers. Instead, you come to us. Now, this health education material in the rural communities, in the local schools, are imparted by school children, school teachers, ASHA workers, ANMs, and our primary health physicians have gone a long way in destroying those myths and superstitions and misbeliefs which are often associated with snakebite. And we also told them about a couple of do's that as much as you can. Many of them, very honestly speaking, we found impractical because it is impossible for a rural woman to walk these shoes and go to the field. Nobody can. It is impossible to find a bed for every member of the household and ask them to sleep in a mosquito net. Well, their home just doesn't permit that, isn't it? But what we can do is that, well, thanks to the Swachh Bharat Abhiyan, we can keep their surroundings uncluttered and ensure that snakes do not easily get into their homes also, that when they walk in the night, that they must have a torch on. And lastly, it is education and education and education, which would probably go a long way, something which we have been doing in rural communities around Sevagram. The COVID-19 has told us, and very rightly everybody realized, that if there is one very extremely weak area in our country is one, public health, and second, our rural health services, which are almost non-existent. And there are several problems associated with rural health services. For example, the problems start in the primary health sector. There are lack of trained doctors here. I mean, during their undergraduate training, the snakebite is often not given the importance that it should be, that the doctors are extremely fearful about gas. And I spoke to a lot of private healthcare doctors in and around Sevagram, where the standard practice is that every patient of a snakebite, venomous or non-venomous, cobra, crate, or a Russell viper, gets 10 ml of anti-snake venom and then is quickly transported to a district hospital or a medical college. And they said that they're extremely fearful about anti-snake venom toxicity, simply because A, they're all alone there. Do not have enough support staff. They do not know the art of intubating or supporting airways. And should something occur in the village, should a villager experience an adverse event, this could be as benign as an urticaria or as serious as a hypotension, and suppose somebody dies in the village, well, they have nobody to look forward to. So their role is everyone gets 10 ml of anti-snake venom, 1 vial of anti-snake venom, and the patients are then transported as soon as possible to the hospital. So these number of factors put together now conspire now to create hurdles in the proper scientific management of snakebite. So a patient of a snakebite would have problems at home, the problems in the primary health center, and even problems in the hospital. In fact, if you have got a patient of a Russell viper or a cobra or a crate, and the viper is quite, and the bite is quite serious, threatening the kidney or robbing the blood of its clotting factors or not letting the lungs to breathe, isn't it? You need at least a good ICU, trained ICU residents, trained ICU nurses. You need mechanical ventilators, you need dialysis machine, you need blood, you need fresh frozen plasma, you need platelets, you need antibiotics, isn't it? Which means that our hospitals must be very well equipped there, and the doctors and the nurses working in the hospital must know how to treat snake bites on a science-driven or data-driven basis. But what is the scene in the country? So before I come to the scene in the country, let me share in a slide or two our MGMS experience, that we looked at our retrospective hospital data between 2014 and 2020. So this data has been updated till 14th September 2021 by our hospital information system. And we found that we admitted close to 2,000 victims of snake bite, of whom about half had venomous snake bite. Of them, 78 died. So the case fatality rate of snake bite is a bit high in our hospital. 7.4, the 95% confidence intervals are hugging the point estimate of 7.4, but this number of 7.4 is a bit disturbing, and we are trying to figure out the predictors of mortality and why people are dying even after they reach our hospital. Our hospital data also shows that if we admit 100 consecutive patients with proven venomous snake bites based on syndromic diagnosis or a 20 WBCT and other markers of antivenom, 55 of them would have a coagulopathy, 22 would have a neurotoxicity, about a fifth of them would have a thrombocytopenia, about a sixth of them would have an acute kidney injury, and half of those who have an acute kidney injury would have a kidney disease sufficiently severe to need dialysis. About a fifth of them would also require a mechanical ventilator. There's a 114 chance that they would have a dangerously low blood pressure, need anotropes, and 8 would die. So this slide captures what happens in the hospital, in a large public not-for-profit teaching hospital, where there is a reasonably good ICU, reasonably efficient doctors and nurses. The dialysis machines are available, the mechanical ventilators are available. But in spite of that, the 8% of the patients of snake bite are dying in our hospital. And now we are trying our best to understand that why this number is abnormally large and what best can we do to reduce this number from 8 to 4. So I was talking about a well-equipped ICUs, and this is a national scene. Now, they are the numbers which came from Government of India last year when somebody was asking about the availability of ICU beds in India for addressing the COVID-19 pandemic. And India had these numbers and these ICU beds and this number of ventilators. Most of these ICU beds and ventilators were located in UP, Karnataka, Maharashtra, Tamil Nadu, West Bengal, Telangana, and Kerala. But the irony is that if we look at the 2020 study about the estimates of snakebite morbidity and mortality in India, we find that these are outside the 7 of the 9 highest snakebite burden states in India. For example, Bihar, Jharkhand, MP, Odisha, Andhra Pradesh, Rajasthan, and Gujarat. They do not have enough number of ICU beds. They do not have enough number of mechanical ventilators even for COVID patients. And these are the states which are sending the highest number of snakebite victims in India. So this huge discrepancy between the people who need ventilators and dialysis machine on one hand, and the availability of these resources not being present in the local hospital creates another problem of how do the people access a very efficient and well-staffed healthcare in our country. So to do that, it's also important that we must boost the production of anti-snake venom. So we need more anti-snake venom. There's no doubt about that. We need an anti-snake venom which really works. And we also need a venom which is relatively safe, which is devoid of adverse events. So how do we get more venom? How do we get better venom? And how do we get safe venom? It is important that we use restrictive Indian laws, the 1972 law on snakes. It needs to be eased, that we must make sure that the horses, the donkeys, the mules, and the camels are treated with respect, and we adhere to the 2017 WHO GP guidelines, that we revive. Many of these anti-venom manufacturing units closed down in the country in the last decade, saying that well, we can't make money from the ASVs, and the government laws are too strict to permit them to make anti-snake venom. And we also need to support development of newer anti-venoms, and this is important. The second part of this sentence is important, against locally prevalent snake species. All through these 4 or 5 decades, we have been occupied with these 4 big ones, but then it is important for us to get out of these 4 big ones and also look at locally snakes, which could be as dangerous, as venomous, and as aggressive as the 4 big ones are. And as I said, that we must follow these WHO guidelines. So having said that, having looked at 20-minute WBCT, having looked at syndromic classification for diagnosis of snake bite, we have some newer methods which could help us detect snake bite. Methods that are accurate, methods that are reliable, and methods which are trustworthy, methods which could be employed at the point of care. So here's a small wish list. So if there is a small child, this child had to diagnose a snake bite, our scientists now must simplify the bedside detection, the point of care test for a bedside to a level where a small school child should be able to accurately and reliably distinguish a viper from a cobra from a Russell viper, and a Russell viper from a saw-scaled viper. So all we need to do is that we need to have some enzyme-linked immunosorbent assays or lateral flow assays, where you put a drop of a blood, and after 20 minutes, you look at this. If it is black, it's saw-scaled. If it is red, it is Russell. If it is blue, then it's great. And if it is yellow, then it is cobra, isn't it? So it's time that our scientific community must design, isn't it, at a point of care test, and the beauty should be very simple, very effective, very accurate, and very reliable, and the most important in our country, they should be affordable. I'm almost tempted to look at the trial evidence for the treatment of acute myocardial infarction and compare it with snake bite. And all that we are doing is that we are treating snake bite even in medical colleges based on a very low quality evidence. And our treatments are all designed based on our own personal views, fancies, idiosyncrasies, traditions, the rituals. And these rituals would differ from unit to unit. Even in medical college, we don't follow the standardized treatment protocols because we don't have any. And our standardized treatment protocols, including the protocols from World Health Organization, are again prepared not on the basis of solid evidence. They are not data driven. So you look at acute myocardial infarction. For a single patient of acute myocardial infarction, we have got wonderfully designed, large volume, very good research, randomized controlled trials, which prove that the blood thinners save life, which tell us that anticoagulants do play a role, which tell us which thrombolytic therapy and what is the window period for a thrombolytic therapy, which tell us what is the points for against a primary angioplasty, anti-lipid drugs, beta blockers, ACE inhibitors, ARBs, bed rest or no bed rest, oxygen or no oxygen, early discharge or a slightly longer hospital day, isn't it? CABG or a master inactivity. We have got evidence for almost everything that is related to an acute myocardial infarction. But when it comes to a snake venomation, well, we have little or no research so far as diagnosis, therapy, prognosis, etiology, or forecasting their future is concerned. In fact, I am tempted to quote this study which looked at the interventions for the management of snake bites, and it did an overview of a systematic reviews, and it tried to rate the qualities of the systematic reviews on snake bite treatment, and it said that there is no strong evidence to either support or refute many interventions related to snake bite animation because the studies are terrible. I mean, they do not pass the filter of being a very good methodological sound study designed on a scientific principles. The sample sizes are awesome. There are tons and tons of biases which are crept in these studies. The outcomes are very different, and often the point estimates of risk reductions are not clinically meaningful or statistically significant. So there is an extremely poor quality of research which is thriving right now so far as snake bite is concerned. So what should research focus on? And I owe this slide to Dr. Ravikar Rao, who very rightly wrote in his 2019 paper in the BMJ that first we must get the numbers right, good epidemiological data, that we must have a high quality anti-snake venom clinical trials which look at both efficacy as well as effectivity and safety of ESV, that we should have tests, we should have preclinical efficacy of antivenom, that we must know what is the accuracy and reliability of syndromic classification to separate out a crate from a viper from a cobra. Can we use these syndromes to guide therapies and to predict the uncertainty? And finally, well, the time has come in 2021 that we must have now newer tests and novel therapies, tests that help us diagnose, the therapies that help us save lives. So what future holds for snake venom? I have adapted this slide from Vellore 2010 Lancet paper, And we all know that a snake venom is a very rich, is a very rich source of enzymes and proteins. An extremely important venom component is this phospholipase A2, which is responsible for great toxicity, presynaptic neurotoxicity. And we all know that when the victims of crate arrive in the hospital, when their eyes are already drooping or they are not breathing properly, it's too late in the day to give them anti-snake venom. So could we have drugs which could block this phospholipase A2, which would be given even before the patients reach into the hospital, right in their home, when they are given a single tablet of a drug, which could block phospholipase A2 and prevent this presynaptic neurotoxicity could be coming. Similarly, in the cobras, we have this three-finger toxin, which is responsible for postsynaptic neurotoxicity. Could we again block this three-finger toxin by orally available drug? And when it comes to vipers, the vipers owe their toxicity to either a snake venom metalloprotease or a snake venom serine protease. And again, if we could have these drugs, they would make sure that these hematotoxins lose their potency, that the blood starts clotting, the kidneys are preserved, they do not go on an acute lightning strike, and the patients go home. So to be effective, these therapies must be available either in the patient's home or in the primary health centers. The drug should be orally available, they should be cheap, they should be affordable, and also important that they should be devoid of side effects. So one such drug is variability, which inhibits snake venom phospholipase A2, which is orally available. There are few clinical trials to show that the drug is promising, but the flip side of the drug is that it has increased the incidence of an acute myocardial infarction because of its blood clotting properties, and therefore we need to have newer versions of this drug here. And the other drugs are atomastat and nanopeptides. And there are some randomized controlled trials of this variability, which appears to be a very potent drug. And then we have got aptamers and therapies which are based on oligomers, peptides, and proteins as well. So this slide, in a nutshell, now explains to you what is in the offering so far as the victims of snakebite are concerned. So on the left side, this is how we are treating our patients right now, that when they are beaten by a snake, either we are incising them or putting them on tourniquet, or they are going to the faith healers, or we are observing for the neurotoxicity or a local inflammation. We are assessing them by a 20-minute WBCT or a good neurological examination. If they are symptomatic, then administering them anti-snake venom or a fresh frozen plasma. And then we are dealing with the complications. So if their lungs fail, we ventilate them. If their kidneys fail, we dialyze them. If their blood doesn't clot, we give them fresh frozen plasma or platelet. And we also administer them anti-snake venom, which has got a number of adverse events, which is potentially not very effective and which requires a lot of time by the time the patient has reached the hospital, and finally it is pretty expensive. The problem with all these therapies are that they are all occurring in the hospital, and therefore it is extremely important for a patient to have access to a hospital where the dialysis machines are there, ventilators are there, anti-snake venom are there, the monitoring systems are in place, and they are backed by a team of efficient doctors and nurses. What in near future, maybe by 2030, 10 years later, that we have future treatments where the patients of snakebite could be diagnosed with of having a venomous snakebite, that the single kit could differentiate a cobra from a crate from a viper with the same ease as a pregnancy test today is doing. So if such tests are available in the patient's primary health centers or the ASHA workers, the first hurdle of making an accurate diagnosis could be solved. And then, if applicable, we should have these novel drugs, which the patients could just swallow a tablet or two, and these drugs would prevent their entry into the hospital, because even with crate victims are no longer getting their eyes drooped, or they are breathing fine, they don't require an intubation or a mechanical ventilation. Again, the drugs are available where they matter most, that is at the patient's bedside, not a patient, even the person's bedside in his home or a primary health center. And if they reach to the hospital, then we will have anti-snake venom, which are not made the way Albert Comet made in 1892, but we will have anti-snake venoms which are made from very highly sophisticated technological driven techniques, and we could have specific monoclonal antibodies directed against snake venom. The advantages of the future treatment would be that, well, they would be cheaper, they would be more potent, they would be case specific, you would have horses for the courses, and the doctors would face very few adverse reactions when they are designing these treatments. Fortunately, the snake bites are getting attention now. It was only 3 days back on 15 September when the WHO launched its platform that specifically deals with information and data on snake bites from all over the world. And the Wellcome Trust has also launched a new 80 million pound program, which is aimed at prevention of snake bites, educating rural communities, getting a highly potent snake bites, and maybe preparing these monoclonal antibodies against snake bites. I'm tempted to quote Professor David Worrell, who last year, writing Lancet editorial, wrote that although the worldwide snake bite has been neglected and forgotten, and it has been abandoned by the scientific community, the worry is that India is a country which sees the most cases of snake bite, where the most people of snake bite die, where the doctors have the greatest experience and skill in dealing with snake bite. And therefore, it is time that the Indian doctors, the Indian healthcare systems, the Indian governments, the policymakers, herpetologists, environment people, researchers, doctors, ANMs, ASHA workers, school children, let everybody join hand and make sure that we achieve that goal of 50% reduction in morbidity and mortality from snake bite. A very important point is that I read just today morning somebody, comic Maya Gopalakrishnan and Preeti Meena. Day before yesterday, wrote this wonderful editorial in the Lancet. And in this Lancet editorial, which arrived yesterday, they wrote, and I really like this line. They say that more attention must be given to people affected by snake bite, as the neglect in NTD is that of the people and not the condition. So it is not snake bite which is being neglected. It is the people who are beaten by snake bite who are neglected, and therefore the emphasis should not be on a snake, but the emphasis should be on victims of snake bite. And it also says that there's a pressing need to additionally focus on the chronic aspects of snake bite, the chronic wounds, non-healing ulcers, amputated lungs, chronic kidney injuries, mental health problems are a huge burden so far as the snake bites are concerned. And this is all the more while because with the introduction of COVID-19 and with COVID-19 pandemic, the funds for snake bite are now getting reduced dramatically. That the attention is again being given probably rightfully to the COVID-19 and snake bite, and the people living in the rural and remote areas now find it very difficult now to access hospitals because of the lockdowns, because of the non-COVID illnesses not being given sufficient importance, because the ICUs getting prematurely closed down and so on. So it is time that we really focus our attention on snake bites. So a wonderful editorial which Soumyadeep and his colleagues wrote day before yesterday in Lancet. So finally, the WHO is there, the Wellcome is there, the environment people are there, the herpetologists are there, the primary health center doctors are there, ASHA workers are there, ANMs are there, school children are there, teachers are there, our doctors, residents, interns, medical students, specialists, researchers, policymakers, bureaucrats, governments, everybody is there. And now that the stage is set, isn't it too much to wish that all the players would play their part and make sure that the mortality and the morbidity of this largely preventable and dreadful disease is really reduced by 50% by 2030. And on that note, I end. Thank you. Thank you so much.